delighted to introduce Martin to us, and I know we're all getting hot, but we've got 40 minutes to go, okay, and then it's refreshment time, and I know over the next 40 minutes you're going to be educated, you are going to be empowered, inspired, no pressure.
Right, well, it's lovely to be here, and I caught the end of Kate's talk on menopause, and it's quite nice that for all the men in the room you're giving us a menopause simulator, so I've been enjoying my afternoon. And I like to think that I'm the embodiment of the best of the last three speakers. So I have the Irish bit, I work in the Northeast, I'm another bald man, so it's hopefully everything you want. Right, so this is the talk, I think it's the third time I've been asked to give it, so surprisingly, having thought it's the worst talk I've ever given, I have been asked to do it twice again, which is an update on all clinical research in MS in 40 minutes with time for questions. And the questions I'm expecting is, why on earth did you try to do that? What have I just sat through, and why didn't I leave? However, we'll try to see how far we can get. So basically, I'm going to talk about a lot of drugs. As many of you know, we've been involved in a lot of these trials in Newcastle, and I've spoken for various companies. I sincerely believe that that's not biasing what I say, but you can tack on me afterwards. So what I'm going to try and do in the next 40 minutes, I'm going to try and give you a very high-level overview of all current clinical trials going on in people with MS. So this is going to be like a balloon floating over France, that you're going to get a vague idea of what's going on underneath. You're not going to get a lot of detail. I'm going to focus on disease modification, and I'm going to tell you more than you can remember. There's going to be more in the slides than you can read through in 40 minutes, but hopefully you'll get a vague idea of what the terrain is. I've used the same slide as I used last time. I'll tell you because I'm going to update it and then decided for sensitivity not to. My worry is that this is going to feel a little bit like reading the shipping forecast, in that you're going to get a lot of just facts with a lot of emotion about them. I was reassured last time to find out there is a 5-hour YouTube video of just the shipping forecast that you can watch, which I think is used as an insomnia aid. And having thought that was the most ridiculous thing people would do, and I haven't shown a slide, there is, however, thousands of hits on the queue for the Queen's coffin, where you can actually watch the live stream of a queue moving. So this talk might feel a little bit like that, and I do apologize. Anyway, what have I prepared for you? So basically, I've gone to clinicaltrials.gov. If you're doing a trial in human patients, you should register that you're doing it. And this is to stop mean drug companies who are paying for this meeting, setting up clinical trials that they get a result that they don't like and bury. So basically, if you're going to do a clinical trial, you have to tell people you're doing it so they can go and look for the result. Okay, so all clinical trials should be registered here. That is quite different from real-world studies and analyses where you can analyze MS base 100 times and only print the 2 results you like. But if you do a clinical trial with real people, you should register it. So if you put in multiple sclerosis and you look for trials that are currently active, that are full, so not recruiting or not yet recruiting, you get 550 trials. I'm not going to deal with all of them, but it is nice to tell your patients that at the minute there are 550 trials going on with real people in MS in the world that have been registered. So I haven't gone over pregnancy registries because you can guess they're all happening. I haven't gone over extension studies of drugs we know or anything I thought was dull. And I haven't gone over very small, very speculative trials. It leaves me with about 100 that I'm going to at least reference in the next 37 minutes. Okay, so topic by topic, let's go through. And again, I'm not going to give you lots of detail. And I meant to say earlier on, why are we doing this? And you will never have to give a talk on this unless you're me. But what you have to do, you all know that patients come in and say what's going on, or they come in with something printed off the internet. There's a study going on in clemistine that says, can I sign up for it? So this is just to give you a vague feel what's going on so you can sound a little bit informed. So pediatrics, a lot of us do adolescent clinics, or at least I do. So what's still going on out there? You maybe know that teriflunomide had a negative trial on its primary outcome measure. So that one is over, but DMF is still going. So DMF is being tried in adolescents 10 to 17s against Avonex. What's interesting here is Avonex has never been proven to work against placebo. So we think it works, but anyway, DMF is in trial against Avonex. Another Biogen one is that Plegridy is in trial against Avonex, so that's kind of interesting head-to-head. What might be the advantage here? If you've treated kids or adolescents, we often do use Avonex because it's once a week. The parents can give it. It's relatively well tolerated, but once a fortnight would be nicer. So if we get the efficacy, this might provide an option. So we're talking earlier about risk aversion, and certainly parents and kids are often very risk averse, so we still curiously, it's where interferons are often used. For the higher level therapies, ocrelizumab, there is a phase 2, just looking open label in kids with ocrelizumab. Interestingly, the phase 3 is going in against fingolimod. Now, fingolimod has a positive trial, so this is the one drug we know works in 10 to 17-year-olds. So ocrelizumab is going in head-to-head against that, and that study is going on at 233, and you'll see the closing date there. Ofatumumab, not to be left out, okay, is going in against fingolimod as well, but interestingly going in a 3-arm study with fingolimod, siponimod, and ocrelizumab, which is interesting. And siponimod has a positive phase 2 trial in relapsing MS, so that's the study they decided to do in kids. So that's going on with kids. Radiologically isolated syndrome, people with MRI MS, but not real MS, and what's going on. So interestingly, ocrelizumab again, okay? Lovely study, this one, and cute. We didn't get involved in it. So you have your scan for your headache, you're found out that you might have MS. You then get 1 year of ocrelizumab, 0, 6, and 12, and then they follow you out to 4 years to see if it makes a difference. So interesting study design, and that's one is going on. That's the cello study. Left field, BCG, and this is, so again, you have your headache scan, it looks like you might have MS, and you get a BCG vaccination. There is something about a phase 2 study, although their main justification was it was safe, cheap, and handy, which is either a good date or a bad date, depending on your preference. Okay, relapses in MS. So what's new for relapses? Obviously, we know about steroids. One drug is being tried to rival steroids. It's a drug called imatinib. Now, we're going to talk about this group of drugs. So the NIBs are tyrosine kinase inhibitors. So when something hits the outside of your cell and you want to get a signal to the inside of the cell, often that involves an enzyme called a tyrosine kinase. There are hundreds of them, and they occur in different cells, and they're linked to different receptors. So if you have a molecule that targets certain form of tyrosine kinase, you can actually interfere with certain cells. So the particular one that this is found in cells of the myeloid and lymphocytic lines. So this drug is already used in chronic myeloid leukemia and acute lymphocytic leukemia, but it will turn off lymphocytes. So basically you have your relapse, you get 14 days of a kind of cancer chemotherapy drug that turns your lymphocytes off, and that is in trial against methylprednisolone and actually due to finish quite soon. So that's kind of interesting. Right, relapsing remitting MS, or relapsing MS is increasingly now is the trials, and we're going to look at new agents. If you're doing nothing else, you can just look at the little diagrams and amuse yourself. They're all from the Noun project, and you can use them for free if you include the artist's name at the bottom. So thank you, Milky, for this one. Okay, so Bruton's tyrosine kinase you're going to hear a whole stack about over the next couple of years, because this is the new kid on the block. So this time, again, you have it there in red. This is the tyrosine kinase. Your B cells are like lonely bridesmaids waiting for their soulmate. They've got their arm out. They're waiting for their one true antigen to come along. When it comes along, unless Bruton's tyrosine kinase can work, the inside of the cell doesn't know that they've met their one true love, and they will never activate. So you can stop B cells working by inhibiting Bruton's tyrosine kinase. Interestingly, the same molecule is involved in signaling in myeloid cells, including microglia, and this is what's so exciting about this drug. We know that targeting B cells works for MS, but what if you could target B cells, and you could target immune cells behind the blood-brain barrier? And all the BTK inhibitors are small molecules that are getting in, so there's a possibility here of doing something outside the brain and something inside the brain. Right, they are all called TNIBs, because TNIBs are tyrosine kinase inhibitors. The longest, or the closest, I think, by a couple of months, is probably evobrutinib, which is the Merck drug. So 2 massive phase 3 trials, nearly 900 patients in each, okay, and it's against teriflunomide, against Avonex, sorry. And that should be coming through, and that's going to tell us whether these drugs work in relapsing remitting disease. There's encouragement here from their phase 2 trial that was significant at 1 dose, though interestingly not the dose that's gone into trial. The next one then is tolobrutinib. So this is the Sanofi product. Again, 2 massive phase 3 studies in relapsing MS, 900 an arm, 2 match studies, should be finishing into next year. But this one, they've been a little bit braver with it. They're also looking at the same drug in primary progressive disease, hoping that that action behind the blood-brain barrier does something, and in non-relapsing secondary progressive disease, as it were, the kind of final frontier of MS therapy. And we've got drugs that work in relapsing, remitting, active secondary progressive, primary progressive, but this is the first drug potentially being deliberately targeted at non-relapsing secondary progressive. Novartis, not to be left out, have remibrutinib, okay? I just hope not all these drugs do not come to market. It's going to be very confusing. Let's hope there's a few winners and a few losers. Again, 2 massive phase 3 studies in relapsing remitting disease, a little bit behind 2025. Roche, not to be left out, have fenobrutinib, okay? So there's a phase 2 Phenopta style. They then have their phase 3 paired Fenhance trial. Fenhance is fun because there already is Menhance, and that's for sale in pub toilets up and down the country. But Fenhance is now here, and it's, again, massive, 700 patients, phase 1-2 in relapsing remitting disease. So again, that one may come. There is a couple coming behind. This is a Chinese biotech company. They have got oral ibrutinib, again at phase 2, again coming through. So I think at the minute it looks like there's at least 5 Bruton's tyrosine kinase inhibitors in trials in humans coming to you potentially for the next couple of years. The efficacy from the phase 2 trials would suggest something that's maybe kind of DMF Fingo-like. Okay, as an oral, we're waiting to see what that looks like. So maybe not the highest level, but it might be. But you've got this potential maybe for working in relapse, in progressive disease. In terms of safety side effects, and there's a bit of noise around the drugs because they're similar to cancer drugs about liver function tests and whether that might be something that would limit their use and how much monitoring they're going to need. But they are out there and coming to a clinic near you. Again, for new agents in relapsing remitting disease, this is a real left field one. Surprised me when I found it. Metenkephalin and tridecatide, okay, put together. It is by Bosnalijek, which is Bosnia's leading pharmaceutical company. So that's good to know. And that one is being tried against Rebif, and let's wait and see. It was actually in my last talk 2 years ago. It's been pushed back because of COVID, but seems to be out there and going. A couple of tiny phase 1s I'll run through. Sizemus is looking at a different anti-B cell drug, a different class of drug. This is from Queen Mary, and they're just looking at the minute to see whether it gets rid of oligoclonal bands, so very early in its trial. Again, this is another very early one. Oh, I tried to practice this in the train, but the man beside me got very teletacicept, okay? And this is a different way of disabling B cells where we seem to hobble 2 of their receptors together. We bind the B cell receptor to APRIL, and it seems to stop them working. It already has shown it works in other autoimmune diseases and is being tried in MS. So again, a different sort of B cell therapy. This is a freaky one, anti-IL-7, so a whole new way of targeting MS. IL-7 is an interesting molecule. We've never really talked about it in MS very much by way of a target, but we know that the IL-7 receptor, if you have one form of it, you're more likely to get MS than if you have another form. So IL-7 seems to be something key in this. This is one of the first, I think, one of the first 3 molecules that came out from the GWAS study. This was one of them. So people are now targeting IL-7. It's been done by GSK. Interesting if you delve into this online. Preparing this talk's always fun because you keep following links and ending down little rabbit holes. That the study was started a while ago and then stopped because of data fraud at one of the sites. So all the early study was wiped, but they've come back and visited again. That's kind of fun. I don't think it was fun for that. I think it was Oxford or Cambridge the guy was doing it. I don't think it was particularly fun for him when he had to rewrite his PhD. You can feel his pain in his introduction. Or her pain, I don't know. Their pain. Okay, right, this is another one. Again, complete one surprised me. So anti-enolase, and what's interesting here is, again, it's an immune modulatory therapy, but we're used to drugs that target the T and B cells. That's the kind of newer, more adaptive immune system. This is going straight for macrophages and monocytes, so these are your normal cleaners. These are cells that do a whole stack of stuff, and this drug is specifically trying to inhibit their function. So how well that works and what the off-side effects are, we'll wait and see, but that's being tried in Taiwan, so another Chinese study or a Taiwanese study, depending on your politics. We'll leave that one out there. Okay, other fun things that people are doing. We mentioned earlier about what drives progression. We know that one thing that seems to be driving progression, and some of that pyra you talked about, a lot of things you mentioned, are these slowly expanding lesions. That when you look sometimes at what looks like an inactive lesion, it has an active rim around it, which is iron. And this is now looking to see if we can target those active rims with a drug that's used for other things, anakinra, which is an IL-1 receptor antagonist. So the interesting thing is, and that's kind of real proof of concept, going directly for pyra with one of the things that we think causes it by looking at a drug. Again, and this is the last one of this. This one caught my eye because it was Emerald Health Pharmaceuticals. I thought it might have been an Irish drug, but it's a different form of green altogether. And this is a synthetic cannabinoid, but we've used a cannabis being used for symptom management. This is looking to see whether cannabis can be used as a disease-modifying therapy. Again, primary outcomes, adverse events, but lots of looking see. So that's what's new for relapsing remitting disease. Right, old dogs, new tricks, okay? So can we use some of our existing medication in fun new ways? Okay, glutarimer acetate always kind of suffered a little bit by the frequency of injections, now being looked at in depot form once a month in relapsing disease and in primary progressive. That's by a company called MAPI. Queen Mary London again, natalizumab. This is a fun study. So we're looking at CIS, but looking to get people within their first 14 days. This is a really interesting study because if you look at the study outcomes, one is to see whether it works, and they're looking to see if jumping in with Tisabri actually means you get less demyelination and healthier looking lesions at the end of 12 weeks. But actually one of the outcomes is to see, can you do a study like this? Can you actually do a study with a 14-day window to recruit people in MS? So that one gets a bit of a call out. Okay, lookalikes, these are the least interesting studies that we have. So there's a company called Immunic AG who are looking at a drug called vidofludimus, which has to be one of the best names ever. Okay, however, it's a drug that seems to look very much like teriflunomide. Two massive studies, two paired against and relapsing with over 1,000 each, and a progressive study. So I think this is filling a real unmet need, because very often I'm looking for a drug. I wish I had a drug that was just like teriflunomide but had a more complicated name. And now it seems that may become a reality. So if there's times that you really wish you prescribed more Teriflu, this is going to be it. Okay, B-cell lookalikes. Okay, again, this is a Russian company. So either they are just taking what's rightfully theirs or moving in someone else's territory, again, depending on your politics. And so this is their anti-CD20, and given by 6 monthly infusion. Sounds a little bit like another drug you might know. So phase 2, but also a phase 3 coming on in that. Again, pushed back a little bit with COVID, but the Merantibus study is up and going. So, old drug, new tricks, the special B-cell edition, okay, and combining two of my little icons here. I spent more time combining those icons than I actually did writing a large part of the talk. Right, so rituximab, hashtag footnote, not licensed for use in MS, okay, but is, however, used widespread. And this is interesting because when it comes to the CD20s, we're all using the infusions. We're looking, are we using too much or too little? And there's quite a lot of studies going out there to look at that. So when they've been using this in Sweden already, they tend to give you 2 grams, which is the full dose, and you maybe get that for the first year, but then they cut down severely. So what this study is looking to do is how far can you cut down and how quickly? Can you cut down to a quarter dose 6 monthly or a quarter dose 12 monthly? And that study is going on. Obviously, this is quite relevant as well for the way we use ocrelizumab. Really weird way to use rituximab of teaching, which is to give someone a stem cell transplant and then give them rituximab intrathecally. And this is being looked at St. Petersburg to try and clear any resident B cells that are left in the immune system. That's kind of fun. Okay, ocrelizumab. So again, we've been thinking we're going to give it 600 milligrams every 6 months. Is that too much? We know that the immunoglobulins are going to fall on people. We worry about long-term risk of infection. So could we maybe just give it the way we give it in MOG-associated disease, only when the B cells come back? So that study is up and going, led from Amsterdam, and I think that one's really interesting. Okay, ocrelizumab, can you give it for a short time and stop? You get rid of a whole stack of B cells. Maybe the ones that come back aren't bad. Maybe you could just give it for a year. Maybe you just give 2 doses of it, which is the John Hopkins study. Give it at 0 and 6 months and then stop. Or maybe you could give it for 1 year or 2 years, which is this study being sponsored by the US, by one of the national institutes, the National Institute of Allergy and Autoimmune Disease, allergy and infectious diseases. And again, they're looking to see is can we give ocrelizumab and stop, and will people get prolonged value from it? So maybe we give less, maybe we can stop. As a complete counterbalance to that, the people that make ocrelizumab are doing studies going, no, you don't want to reduce the dose, you don't want to stop, you want to give even more. Okay, so this is, can we double or treble the dose of ocrelizumab and get more effect out of it? And the interest here is that when you look at the primary progressive trial, lighter patients did better. So it looks like if you get more ocrelizumab per gram of your body weight, you do better. So what if we give everyone a bit more? And that's being looked at in a big study in relapsing disease and in primary progressive disease. So we are trying to find, and for a lot of my patients now, I'm putting these drugs, I'm going to give it to you every 6 months. I have no idea what I'm going to give it to you long term. I could be giving you less, I could be giving you more, I could be spreading it out, but we'll find that out by the time you get to 3 to 4 years. Ocrelizumab, okay, obviously given IV. Subcut, ofatumumab is subcut. Ocrelizumab is looking to see whether it works subcut as well. So that will interestingly give us a choice potentially. Is it the drugs that are different? Is it the route that is different? So yeah, stand back and watch the fireworks. Right. Repurposing. Okay, these are drugs that we use for other things that are creeping into MS. Minocycline, many of you use for acne and various bits and pieces. Okay, it's an antibacterial. And it does, however, also affect the way immune cells move around. So it's an and it's been used already. Quite positive. Short study already in Calgary suggesting it might work, and the long-term follow-up that is going. So it'll be interesting to see if we go for that. Cheap as chips. Okay, and I think often when we're looking at drugs that are going to work in developed countries, I think things like minocycline, and I'm not saying that we shouldn't be trying to get our better drugs all around the world, but if you've got a drug like minocycline that did a lot of what the bigger drugs do, this is something that really could be rolled out. Again, from Calgary, hydroxychloroquine, a lot of you will know from use in rheumatology, indapamide, an antihypertensive. Again, phase 2 study in Calgary to see whether there's anything in that. Metformin, okay, I think I'm going to talk later about metformin use as a neuroprotective, which we know already, but this is metformin being used as an add-on in relapsing remitting disease in a study coming from Egypt. Famciclovir, an antiviral, again being used as an add-on to natalizumab from Queen Mary, looking to see whether it can actually, is anti-Epstein-Barr virus thing actually works. Short study, this is just to see whether it does actually work on reducing Epstein-Barr shedding, and if it does, then that might be part of a bigger study. And then my upcycling logo, that's one I got to do, which is this is good old-fashioned mitoxantrone has now been upcycled into liposomal mitoxantrone, okay, which is probably just costs a whole stack more than old mitoxantrone, but I guess that this is hope that it gets rid of the fact that mitoxantrone, great drug for MS, but tends to kill people, that it might do the great things for MS, but not kill them so often, and this drug is now in a phase 2. Right, that's all the new things. Head-to-heads, okay, we all like a good fight, and there's a good debate tomorrow. It's me and Kate tomorrow, by the way. Don't forget to vote. So what heads do I have? So this is in Karolinska. Again, the Swedes love their rituximab, okay? They also love the far right, but they seem to love rituximab more, okay? And if you've been following their elections, which is a little strange. Okay, but anyway, what we have here is basically rituximab versus everything else. And it's being run as an observational study, and that will be interesting to see, both for the CD20 argument and for rituximab being used off-label. I think these are fun studies, okay? So obviously, rituximab and ocrelizumab, different molecules, lots of difference between them, but the big difference between them is the price, okay? So are they clinically different? So we have the Dan norm study, which is looking at Ritux versus Ocra 2-to-1 head-to-head. And then my second favorite acronym of the Overlord study from Norway, which is, would you like to take part in the Overlord study? And who wouldn't, okay? And that's going to, so, and look at the dates in those. So within the next couple of years, we could be sitting on high-quality, randomized, controlled data showing that there's no difference between rituximab and ocrelizumab, and that leads us into an interesting world. Okay, studies directly done on progressive MS to whiz through. Melatonin, an interesting one. Okay, so given there the blurb from this. However, if you use melatonin, the dose we have is 2 milligrams. Okay, so this is a shed load of melatonin to be used in addition to your ocrelizumab. Presumably you take it in the night. Okay, but so 100 milligrams of melatonin, people where fatigue is the biggest side effect. Yeah, that'll be a fun one. Okay. MS Stat 2, Jeremy, what can I say? We have to wave the flag, and that's up and going, fully recruited and running through. Masitinib's an interesting one. So this is another tyrosine kinase inhibitor, but this time it's targeting mast cells. Now, I did immunology many years ago. If you asked me the one cell that I thought probably wasn't involved in MS, you'd say mast cells. It's like your allergy one. It's, we have mast cell stabilizers for asthma. It seems to be a completely different part of the immune system, but positive early trials are now up and going, and the study is up and recruiting, looking at masitinib in progressive disease of various sorts. Again, have to fly the flag for Klaus and the Chariot study, and it's cladribine, so again, kind of old drug, new tricks, but trying to see if it would work at preserving upper limb function in patients with advanced MS. Okay, and credit to them, look what they're trying to recruit, 6.5 to 8.5. So when I tell our research nurses that we're up to 6.5, they go, good grief, that's going to take ages getting people in and out of clinic. I think this is a study really looking at an on-touch group of people, so massive credit for trying this one. So up to now, we've talked about ways of altering the immune system with small drugs, okay, and either small molecules or antibodies. What about actually using cells themselves? And this is a kind of trendy place that we're going. So mesenchymal stem cells are cells that you have in your body. They are stem cells and they can keep on reproducing and replacing themselves, but these cells do not go on to make neurons. Okay? Usually they go on to make muscle, connective tissue, and bone. However, mesenchymal stem cells seem to be like your body's rapid response. Okay? So we have like rapid response cleaners in the hospital, that kind of come around and or those kind of short-term physio supports. And your mesenchymal stem cells will just go to areas of damage and start to do stuff. They have anti-inflammatory effects. They fuse with other cells. They seem to act like external power packs for dying cells. They do all sorts of good things that would be nice in MS, and we can get them from various parts of the body. And the hope is that although they will not regrow brain, so they're stem cells but not trying to regrow the damaging, that they might promote regeneration from the nervous system and they might support dying tissues. So these are various studies. I'm going to flick through them. So this is looking at getting them from your bone marrow and then putting them intrathecally as a single dose. This is again looking at some embryonic-derived mesenchymal stem cells. Again, these are done by infusion, looking to see whether people with progressive disease can improve. These ones are getting from adipose tissue. Okay, so you get some of your own fat taken out, get the mesenchymal stem cells from that, and then they're putting them back in as infusions, looking to see if your quality of life improves. Maybe just because you've had your fat taken out, that would help. Another source of stem cells can be human umbilical cords. So this is, again, getting intrathecal infusion of umbilical cord cells, not from yourself, unless you stored your own. So some little baby is milked, and then you lie there, get a lumbar puncture, and they go straight across. That's a fun study, not one we're taking part in. Okay, this is a slightly more interesting one, where again they're getting these mesenchymal stem cells, but they're manipulating them to make them into neural progenitor cells outside. So then they're infusing intrathecally into you. They're giving you back cells that might go to make new brain. So that's kind of fun and a number. So good to know that's out there. I've put these three together because they're all the same mechanism, which is that we think, and increasingly the MS, you've read all the Epstein-Barr stuff. Epstein-Barr lives in B cells. So it's the thought that those chronically infected Epstein-Barr C cells are baddies. One of the ways of killing those is to make your own T cells turn on them. So what these three studies are doing is taking, well, the first one takes your own T cells out. It conditions them in vitro to hate Epstein-Barr, okay? It then sends them back into you, and it goes and kills all your B cells that are infected with Epstein-Barr. So that is that one. These ones use an off-the-shelf one. They're both by the same company. It's the same study at different bits, ATA188, which is that they have made a kind of, I think, like slightly off-the-shelf ones, which roughly match your HLA type, so they're not going to be massively graft versus host. So you get one that looks a bit like you. And again, Epstein-Barr infuse these, and it goes and kills all your Epstein-Barr B cells. So that's a kind of novel way of treating MS. Dendritic cells are the cells that you have in your body that usually hoover stuff up and show it to your immune system. When your dendritic cell picks up a molecule, it shows it to a T or B cell, but it also tells it where it found it. So it'll say, I found this in the middle of an infection. It's probably dangerous. And that makes your T or B cell react to it. Or it may say, I found this molecule. It was just in the middle of your liver. It's probably a bit of your liver. I suggest you ignore it. Okay? And the T and the B cells calm down and become tolerogenic. So your dendritic cell, when it presents, can present in an aggressive way that tells it to react, or it can present in a way, please ignore this, it's just a bit of you, okay? So what these studies are all doing is taking your dendritic cells out, showing them myelin in a way that makes them think it's friendly, okay? And then they put it back into you, so the next time it sees myelin, it'll present it to T or B cell, even if it's a myelin reactive, go, I found this, but look, it's you, okay? And then they relax, okay? So this is tolerogenic dendritic cells. I've got it in various ways. Unfortunately, they seem to be quite keen at getting them as close to the brain as we can. So these ones will give them into your supraclavicular, back in there. Okay, these ones just do it IV. These ones actually give it into your lymph nodes, okay, by direct injection. So that, again, not doing those studies either. This was real fun. I didn't know this was up and going, but this is actually already used. You've seen people getting plasmapheresis, okay, and various forms of leukapheresis. So what this machine does is it takes your blood out, and it puts it through, puts it in the tube, and then it shines UV light onto your blood. Okay, and the UV light makes your lymphocytes apoptose. Okay, they then, as they're nicely dying, you then infuse them back in, and then they go to die gracefully in your body. Okay, but when cells die quietly by apoptosis, they tend to calm everything down around them, okay? And you get this peaceful, as opposed to a necrotic dying cell, apoptotic dying cells are anti-inflammatory. This is already used for graft versus host disease. Maybe some of you knew that. I had to look the whole thing up and steal a picture. So this is being used now. It's been used and it's looking at MS, taking it out, sending apoptosing lymphocytes back in. They hope that they get into the brain, apoptose, and calm everything down. That's kind of fun. Okay. Other forms of vaccination. This is, again, ways of trying to make you think that, remind you that myelin is part of you and not something you're trying to attack. So this is an altered MOG peptide that will be given. This is interesting because this technique of altered peptide ligand was tried about 20 years ago and stopped when it really made several people with MS got really badly worse. Okay, that actually it just made them more reactive to myelin rather than less, but this one's being looked at again. Okay, and then we have this Neurovax, which is a very trendy, I won't go into the full kind of chemistry behind it, looking at the T-cell receptors, again, looking to tolerize people externally and then re-tolerize them with this, okay? This is another way of tolerizing it, a very interesting one, where they've got a secretly previously identified myelin antigen, which they've taken out. They then glycosylate it so that it goes to your liver, so your liver now expresses myelin, okay? And now your body finds myelin in the liver, it absolutely thinks it's part of itself and re-tolerizes again. So these are kind of clever ways of trying to manipulate the immune system and to be friendly towards myelin. A quick romp through hematopoietic stem cell transplant. Don't forget, still licensed in the UK, but we've still got studies going on against alemtuzumab. Is it better than existing therapies? This is in Norway. And again, the big US one, Beat MS. Is it better than existing therapies going in against what's out there? Interestingly, STAR MS is not registered in clinicaltrials.gov as far as I can find. And I did go looking for it to see. So if it is a negative trial, we can just bury it. No one ever knows it took place. And I do apologize if it is there and I just didn't find it. But I did go looking because I knew it should be. Okay, this is, so usually what we're talking about with stem cell transplant is autologous, where we take your own stem cells out and give them back to regrow your immune system after we wiped it out. There's a slight flaw in that, potentially, in that your own immune system made the mistake once before to give you MS. So we take your own immune system away, we wipe it out, and then we give it back to you again. What's to stop it making the same mistake again? So allogenic would be giving you someone else's immune system to regrow your own. You then have a chimera where I am Martin, mostly Martin, but my immune system is Kate, okay? And we kind of live in a chimeric state, and this is being looked at as well. N equals 3, okay? So yeah, we'll see. If those 3 get through, we'll think about it. Okay, neuroprotection. We're getting near the end, yeah. Okay, right, so we've talked about before about trying to stop your immune system attacking the brain. What about making your brain more resilient? Okay, getting that little umbrella up. So clemistine, as many of you will know, because patients seem to have found this one out, many of our patients are actually taking it already, is an old-fashioned antihistamine. Again, its main side effect is sedation. So we're giving, in fact, clemistine was dropped as an antihistamine, and we used the modern ones because so many people felt tired on it. Okay, we're now using it as a treatment for people with MS. Okay, but however, it has been shown potentially in early studies to help myelin grow back again, okay, and be remyelinating. So it's exciting from that point of view. So Cambridge are looking at 2 drugs in combination, clemistine and metformin together, to look to see in patients with damaged optic nerves whether we can get that optic nerve to work better again. Clemistine on its own is being used, very similar again in optic nerve, this one very quickly after optic neuritis from San Francisco, and in Amsterdam one looking at people with an INO, and they have a little machine that measures your INO and how your eyes moved, and they're looking to see whether clemistine can make your eyes move better. So again, interesting technique. Other drugs being looked at, N-acetylcysteine, again from San Francisco, primary outcome measure brain spinal cord atrophy. Nanocrystalline gold, okay, again, from left field somewhere. Have you ever thought of getting gold and just giving it to people? But it seems to be vaguely neuroprotective. And again, that's being used. This is now in the open label extension in the visionary MS. I might just take the gold and do something else with it. We heard about hormones before, okay? So this is looking at testosterone, which appears to be vaguely neuroprotective. So again, looking at neurodegeneration and repair, investigator-led from Strasbourg, looking at thalamic volume and MRI outcomes. And just for the girlies, okay, there is azadoxifene, okay, which is a 3rd-generation selective estrogen receptor modulator, okay? And this is one of those kind of mechanized ones where they just put thousands of drugs through a remyelinating model. This one came out as potentially being pro-remyelinating. Okay, the study is only for women, okay, and they're looking to see what it does to their VEPs, and that's going to run for 3 to 6 months, again, from San Francisco, so again, a little bit interesting. The microbiome, okay, this is, again, this notion that your immune system and your brain hugely depend on what is in your gut. So, two rather unpleasant studies, okay, again from San Francisco. This one, we give you antibiotics to sterilize your gut, and then by colonoscopy, you get 3 doses of someone else's poo, okay? This is run from, I think, and I have to say, because I never get to say this in public, 3 words you thought you'd never say in public, from a non-profit stool bank. Again, I'll say it, a non-profit stool bank is used for this one. Okay, if you don't like getting someone else's poo by colonoscopy, you can just swallow it. Okay, so again, this one, these come as, again, this has, you know a sales team has been involved here, oral fecal microbial transplant capsules. Yeah, I can say no more. Vitamin D in diet. Okay, so, I meant to say, remember I told you earlier that Overlord MS was my second favorite? Actually, ReWrap, which was the estrogen one. Imagine calling a remyelination therapy the ReWrap study. I think that they get today's prize. But a close run-up is the vitamin D, can it stop you getting an MS after CIS, called the D-laced MS, which you have to give them that one. So again, run for the University of Nîmes, CIS, high-dose vitamin D, looking to see whether it stops you going through lipoic acid again on the dietary side. Okay, 4 minutes left, we'll get there. Okay, starting strategies. Okay, so MS-based, we've talked about this before, and David has referred to the study. When we look back, it really does look like starting high efficacy early is better than starting by escalation. Okay, to the extent that maybe not all of us believe that is still an equipoise, okay, but when all said and done, it has been done retrospectively. There are 2 prospective randomized studies looking to do this, which is Deliver MS run in the UK, actually from Nottingham, and then also Treat MS from Johns Hopkins, looking to randomize people to an escalation strategy or to high dose early. So this should answer the question definitively if the studies go on through. This is a beautifully designed study. So beautifully designed, we decided not to take part in it. Okay, but again, highlight, if you didn't like, you get randomized, and then if you don't like what you got randomized to, you can actually stay in the study but take a drug of your choice and be observed. Okay, so whether or not that ends up undermining the study or not, I thought it would. Okay, it kind of remains, but that study is up and going. Stopping, we've talked about. Now, thankfully, you already mentioned the DISCO study, which is sort of number 4. Okay, I'll have DISCO MS study, which is the discontinuation one. We said before, it looks a little bit like stopping drugs, doesn't do anything to your relapses or EDSS, but a little bit more MRI activity, but actually quite low figures. You know, so with 12% activity on those that stopped, 5% activity, you know, these are people over 55, but no evidence that made much clinical difference, okay? So that is being continued on, those patients are being followed through. Again, we need to know who we can stop safely on and who we're at risk on. 2 other similar studies, so STOP SCP is the French one. Again, 2-year follow-up, looking at people over 50 on DMT for 3 years with no GAD. And the one from Amsterdam, again, 5 years stable to look to see who can we stop safely. And then I'm going to close with 1 non-DMT study. So everything up to now has been, which is, again, this is basically the one that tickled my fancy, okay, which is the backward walking training in MS, okay. And they say lots of people fall with MS, but no one has ever done a study to see whether backward walking training would reduce the falls risk in persons with MS. That doesn't feel like a justification to do a study. Which is, you know, in terms of, you know, whatever you're going to, no one's done backward walking to see what it does with cancer. Okay, it's probably still not a reason to doing it. However, it is up and going. There are 90 patients in it. It's estimated to complete in 2 years. And the primary outcome will be their sway during quiet stance. Okay, and stepping latency on push and release at 8 weeks. So there you go. If your patients want to say, what could I do that could help, you go, practice walking backwards and see how it goes. Okay, the next slide is my final slide, and I can honestly say that compared to everything else I've done, this took more time than the rest. Okay, here comes the summary slide with all my computer skills in one go. Wait, it gets better.